Good evening. We'll start at the top of the hour. If our first presenter can put up their slides, we'll appreciate that. Let me do that now.
Okay, can you allow me to share my screen?
Good evening, ladies and gentlemen. Welcome today to yet another meeting of the Nigerian Society for Colorectal Disorders. Today, we'll be moving away from norm and dealing with a pathologic disease today. We are discussing the invisible time bomb, which is understanding the pathologic basis of familial adenomatous polyposis. We will be having today two presenters. Dr. Nwosu Ivan Therese will be doing our case presentation, and this will be followed by the meat of the matter, which will be taken by Professor Francis Ukekwe. So we'll start by handing over to our moderator. Is our moderator around yet? Let me check. To kick off the presentation with the case presentation. Check.
Okay. Good evening, professors, consultants, and members of Nigerian Society for Colorectal Disorders on this call. I'm Dr. Nwosu, taking the case summary. The patient is a 45-year-old male commercial driver who presented with diarrhea of 2 months duration. Diarrhea was sudden in onset with a frequency of about 5 to 6 times a day, as opposed to bowel motion of 1 to 2 times a day before the illness. The quantity was estimated to be about 100 to 150 ml per bowel motion. There was presence of frank blood in the stool, which stained the stool, but sometimes mixed with stool. There was associated abdominal pain located at lower quadrant, dull, intermittent, with no aggravating or relieving factors. There was also tenesmus, fatigue, and weight loss. There was no history of abdominal swelling, vomiting, loss of appetite, yellowness of the eyes, easy satiety, cough, chest pain, breathlessness, bone pain, or history of exposure to radiation. On account of the above complaints, the patient was on analgesics and antibiotics bought over the counter. However, symptoms persisted. This prompted him to present to University of Nigeria Teaching Hospital, Enugu. He was first reviewed by the gastroenterologist, who requested for investigations and afterwards referred him to the general surgery unit. The patient is a known hypertensive, but not a known diabetic. He had stroke about 1 year prior to presentation, and 3 months later, he developed seizures, and he was being managed by the neurology team for post-stroke seizure disorder and has been on oral levetiracetam. He is the last child in a family of 5 children, married with 1 child. His mother was said to have died from complications of change in bowel habit, but she was never properly evaluated. He does not drink alcohol or smoke cigarettes. General examination revealed moderate pallor, no jaundice, and no peripheral lymphadenopathy. Abdominal examination showed moderate abdominal tenderness at the left iliac region, but no palpable organomegaly. Rectal examination revealed good perianal hygiene, good sphincter tone, and a few nodules were felt on the anterior rectal wall. The prostate was mildly enlarged, firm in consistency. The median groove and lateral sulci preserved. There were no prominent nodules, and rectal mucosa was free. A clinical diagnosis of chronic diarrhea of unknown origin, probably due to colon polyps, was made. The patient was sent for further investigations, including a colonoscopy, which showed widespread polyps of various sizes and shapes. Some were pedunculated, while others were sessile, spanning from the anal canal to the cecum, greater than 300 in numbers. There were also 2 large obstructing tumors, one at about 30 cm scope length and the other at 50 cm. Both were necrotic and bled easily on contact. A diagnosis of familial adenomatous polyposis with 2 colonic tumors, one at the rectosigmoid and the other at the ascending colon, was made. Biopsies were also taken for histologic section from both specimens, which were similar and showed a polypoidal colonic mucosa covered with severely dysplastic epithelium. The impression was descending and rectosigmoid colon adenomatous polyps with severe dysplasia. The patient underwent an upper gastrointestinal endoscopy, which showed antral polyps. The computed tomography of the abdomen was done, which revealed that there was an enhanced circumferential rectosigmoid mass, which is about 6.1 cm by 4.2 cm with partial obstruction. There were few mesenteric lymphadenopathies, no ascites, and no tumor thrombosis were seen in the abdominal vessels. Brain CT features are consistent with chronic ischemic stroke involving the left half of the occipital lobe. He was also reviewed by the ophthalmologist, who noted good vision and nothing suggestive of hypertrophy of the retinal pigment epithelium. The patient was canceled on his diagnosis and surgical options. He accepted total colectomy with ileorectal anastomosis. He had total colonic washout done till clear fluid was returned. He had exploratory laparotomy under general anesthesia with the following findings: multiple enlarged mesenteric lymph nodes, hundreds of colonic polyps of varying sizes extending through the whole colon, no liver metastasis, no duodenal or gastric tumors, no peritoneal seeding, and no ascites. He had a total colectomy with ileorectal anastomosis. After the surgery, the patient continued to be on nil peoris and intravenous fluid with potassium supplementation, intravenous antibiotics, analgesics, and intravenous phenytoin were also given, as the patient was having a seizure disorder. The patient was commenced on graded oral fluid intake on the 3rd day post-operative, which was upgraded to normal oral feed intake by the 5th post-operative day. The patient experienced an increase in frequency of stooling, for which he was placed on oral loperamide. He was subsequently discharged 9 days after the operation and has been seen in outpatient clinic 2 weeks after the discharge. So these were the intra-op picture of the patient's of the surgery. So that's the colon with multiple polyps, as we can see in the pictures. So this is a closer look. Multiple polyps. Thank you for listening.
Thank you so much for the presentation. I don't know if Professor Ukekwe is up for his presentation, or is Professor Ukekwe on? Yes, okay, I can see.
Can I share my slide?
Okay, so I was wondering if we can go through your presentation and then we can have a conversation after that.
Hello.
Yes, we can hear you clearly.
Can you see my slide?
Yes, we can see your slide.
Okay, thank you.
Yeah.
I'm Professor Francis Ukekwe from University of Nigeria Teaching Hospital. It's a pleasure for me to be given this opportunity to have this presentation before the Nigerian Society for Colorectal Disorders. The theme before us is Invisible Time Bomb, Understanding the Pathologic Basis of Familial Adenomatous Polyposis. By way of introduction, adenomatous polyposis is actually eventually leads to colorectal cancer. So I decided to start from colorectal cancer, just a brief introduction. Colorectal cancer is the third most commonly diagnosed cancer worldwide. Hereditary colorectal carcinoma cancer syndromes account for approximately 5 to 10% of all colorectal carcinomas or cancers, with a lifetime risk that approaches about 50 to 80% in the absence of endoscopic or surgical treatment. Hereditary cancer syndromes can phenotypically be divided into polyposis and non-polyposis syndromes, mainly according to the condition of the polyps. Over the years, molecular genetics have actually evolved, providing us now with cancer ability to discover cancer predisposing genes, and this has helped us in better management or in better improvement in the field of clinical oncology. Hereditary cancer syndromes have a key part in this effort, with data showing that pathogenic variants are present in up to 10% of cases. Molecular phenotypes of tumors can help identify individuals with genetic susceptibility to colorectal cancer and also guide precision prevention and treatment for the development of colorectal cancer. Advances in immunohistochemical and molecular techniques shed new light on the origin, classification, progression risk of different entities associated with colorectal cancer. Endoscopic surveillance significantly reduces cancer incidence and improves survival rates, highlighting the importance of continuous advancements and updated guidelines to enhance patient care. Familial adenomatous polyposis is a rare genetic disorder with autosomal dominant inheritance, defined by presence of numerous adenomatous polyps, which inevitably progress to colorectal cancer unless they are detected and managed early. It is defined as an autosomal dominant inherited condition caused by germline mutation in the APC gene on chromosome 5, on the long arm of chromosome 5, region 2, band 1. Some people, about 25% of patients that have familial adenomatous polyposis and no family history, acquire a new abnormal APC gene. This is called the de novo mutation. So besides those that have this inheritable FAP or familial adenomatous polyposis, some also develop familial adenomatous polyposis de novo. Familial adenomatous polyposis is also known as adenomatous polyposis coli or familial polyposis coli. Greater than 70% of patients with this syndrome also develop extraintestinal manifestations, such as multiple osteomas, dental abnormalities, and a variety of other lesions located throughout the body. So this adenomatous polyposis coli also can be associated with other extraintestinal manifestations. These manifestations have historically been subcategorized into other syndromes, such as the Gardner syndrome, Two-Cut syndrome, and other proximal polyposis of the stomach and gastric adenocarcinoma, other conditions. By way of epidemiology, familial adenomatous polyposis has an incidence at birth of about 1 to 1 per 8,000 in some climes. In others, other researchers have published incidence of 1 in 7,000 to 1 in 10,000 new births. In the United States, for instance, some have published 1 in 8,000 to 1 in 18,000 individuals, or 2.29 to 3.2%, 2.29 to 3.2 per 100,000 people in the United States. Males and females are equally affected worldwide. Familial adenomatous polyposis accounts for less than 1% of colorectal cancer cases. In the European Union, prevalence has been estimated to be about 1 in 11,300 to 37,600 cases. It prototypically results in formation of numerous, essentially more than 100 adenomatous polyps. And these polyps are growths within the epithelium of the large intestine. Colon polyps typically present at the second at the end of the second decade, with a mean age of about 15.9 years. Hello, can you still see my screen? Hello?
Yes, we can still do.
We can see.
Thank you. Essentially, about 100% of patients with classic familial adenomatous polyposis develop colonic adenocarcinoma when there is no surgical intervention at an average age of about 39 years. 25% of such patients will be diagnosed with colorectal cancer at the time of presentation. It is primarily associated with a significant risk of colorectal cancer and increased risk of other cancers such as pancreatic carcinoma, thyroid carcinoma, etc. Most patients are asymptomatic for years until the adenomas are large and numerous and cause rectal bleeding, anemia, or even the cancer develops. Familial adenomatous polyps, adenomatous polyposis polyps begin as benign lesions, but eventually undergo malignant transformation into colon cancer when left untreated. There are some classifications have classified familial adenomatous polyposis as having two main types, the classic type and the autosomal recessive FAP or the MUT-associated polyposis. Whereas some have tried to classify FAP as consisting of three, essentially the classic type, attenuated type, and the autosomal recessive FAP, or the MUT-associated polyposis. Inherited, looking at the classic FAP, which is the main culprit, it's inherited in an autosomal dominant manner, results from a germline mutation in adenomatous polyposis, that is APC gene, as I said earlier on the long arm of chromosome 5, region 2, band 1. Most of these patients, about 70% of them, have a family history of colorectal polyps and cancer. Usually there is a relative that has this condition or that has died from this condition. Most frequent genetic polyposis syndrome, it is the most frequent polyposis syndrome. It's also more severe than other FAP types and develops colon polyps early in childhood. By age 35, 95% of people with classic FAP will have colon polyps. It's associated with hundreds to thousands of colonic polyps. Greater than 100 colonic polyps, adenomatous polyps, are actually important for the diagnosis. Essentially, 100% lifetime risk of colorectal adenocarcinoma results in colonic polyps and cancers that are initially confined to the colonic wall. Detection and removal before metastasis outside the colon can greatly reduce and in many cases eliminate the spread of the cancer. There are also variants of this classic familial adenomatous polyposis, which includes the Gardner syndrome, Tocqueville syndrome, and attenuated familial adenomatous polyposis. So looking at the attenuated type of FAP, which is the second form of FAP, originally called hereditary flat adenoma syndrome. It has a functional but slightly impaired APC gene. It's also inherited in an autosomal dominant pattern, but in this case, the gene is there, but it's impaired, and the impairment is at the chromosome 5 also, where the gene is located. This presents with a milder, less aggressive form, has a delayed growth pattern, develops at a later age. Both the polyp and the cancer has a late onset. Fewer colorectal cancer adenomatous polyps are actually found, usually between 10 and 100. And as I said, it has a low cancer risk as well. So mutation occurs close to the end of chromosome 5 prime end of the APC gene, and is therefore somewhat able to operate as usual. Attenuated familial adenomatous polyposis still presents a high 70% life risk of cancer, as estimated. Whereas in the classic FAP, there is about 100% lifetime risk, but typically presents with fewer polyps, typically about 30 rather than the hundreds or thousands that are found in the classic familial adenomatous polyposis. It arises at an age when FAP is usually no longer considered likely, occurring about 40 to 70, within 40 to 70 years, an average of 55 years, rather than the more usual 30s upwards, during which the classic familial adenomatous polyposis presents. Has different management options due to its fewer polyps. The third type of familial adenomatous polyposis is called the autosomal recessive. It is inherited in a recessive, autosomal recessive manner, unlike the classic and attenuated FAP that are inherited as autosomal dominant conditions. This autosomal recessive familial adenomatous polyposis is also called the MUT associated polyposis, or MAP for short. An autosomal recessive inherited polyposis condition caused by mutation in the MUT or MYH gene located on chromosome 1, short arm of chromosome 1, region 3, band 4, which is actually a base excision repair gene. It's a milder form of polyposis characterized by presence of fewer polyps, occurs in a few subset of individuals, characterized by increased risk of developing colorectal cancer and polyps and adenomas in both upper and lower GI tracts. The MUT-associated polyposis has been associated with malignancies of the duodenum, ovaries, urinary bladder, and skin. Autosomal recessive continuation. Diagnosis of this condition is based on suggestive family history, positive suggestive family history, clinical findings, large bowel endoscopy or full colonoscopy. Genetic testing is recommended for individuals that have greater than or equal to 20 polyps and may be considered in individuals with 10 to 20 polyps with other personal or family features. Then you have the Gardner syndrome. This essentially has an incidence of 1 per million in the United States. The Gardner syndrome is essentially the classic familial adenomatous polyposis that has other associations, essentially extra-intestinal lesions, desmoid tumors, skull, mandible, bone osteomas, fibromas of the scalp, shoulders, arms, and the back. Then you have the Tocqueville syndrome. This is also associated with primary brain tumors. This is also associated with familial adenomatous polyposis, but these individuals have also primary brain tumors in addition with the colorectal cancer. Hereditary non-polyposis colorectal cancer and familial adenomatous polyposis are the two most well-known inherited colorectal cancers. It encompasses a subset of FAP with brain, that is the Tucker syndrome. And the two brain tumors they normally have are the medulloblastomas. Etiopathogenesis, we will look at genetics of FAP and then pathogenesis. So FAP can be, by way of genetics, discussing genetics of FAP can have different inheritance patterns and different genetic causes. When familial adenomatous polyposis results from mutations in the APC gene, it is inherited in autosomal dominant pattern, which means for one to have this condition, it just needs a copy of the altered gene from maybe a parent. And normally in this condition, you will find a history that there is a parent with the gene. In most cases, the affected person have one parent with the condition. Incidence of malignance, like I said, is about 100%. It has a 100% penetrance. So hereditary colorectal carcinoma syndromes are usually due to defect in the gene, APC gene. And the polyposis without APC gene often have mutations in the MY gene. Autosomal dominant trait with high degree of penetrance, more than 90%. The incidence of malignancy in these cases approaches 100%. 20% represent de novo cases without family history. So in as much as we have the hereditary type of FAP, we also have the de novo types that arise as a result of, what do I call it now? De novo modifications, mutations in the APC gene. So the APC gene is a tumor suppressor gene responsible for production of the adenomatous polyposis cola. It's a large multifunction tumor suppressing protein. This APC gene codes for the APC, which is a protein that is a tumor suppressor protein. It's actually a gatekeeper to prevent development of tumors. So, and what it does is that it regulates beta-catenin, a protein that plays a crucial role in cell communication, signaling, growth, and controlled destruction, but which, if left uncontrolled, can give rise to numerous cancers. So if the beta-catenin is not regulated by the APC gene, APC protein, that is now in this case in the FAP that is modified due to mutation, then you see that you have uncontrolled growth, polyposis that can now eventually undergo malignant transformation to cancer. A defect in the APC gene means APC gene is not effective as it should be. And over time, it's likely that some cells that are supposed to be controlled by the APG will not be, and instead they will continue to proliferate and become cancerous. In familial polyposis, they usually manifest as polyps that are small abnormalities on the surface of the intestinal tract. Although the polyps are inherently benign, the first step of the two-hit hypothesis have already taken place by the inheritance of the abnormal APC gene or the APC mutation. Often the remaining normal allele is mutated or deleted, accelerating generation of polyps. Further mutations are as a result of mutations in P53 and KRAS genes to the APC mutated cells. They are more likely to lead to cancer than would in non-mutated epithelial cells. The normal function of the APC product is still being investigated. It is in both the cell nucleus and the membrane. Canonical tumor suppressor function of APC is suppression of P-catenin. But other tumor suppressor functions of APC may be related to cell adherence and cytoskeleton organization. Mutation of APC also occurs commonly in incident cases of colorectal cancer, emphasizing its importance in the formation of cancer. So we look at the other type of familial adenomatous polyposis. which is the recessive type, which is the MUTAYH, or MUT-associated polyposis, or MAP. This is caused by mutations in the MUT gene. It's also a tumor suppressor gene that is inherited in autosomal recessive pattern, meaning that for one to have the condition, one must have the two alleles that are affected for it. Maybe the parents, maybe both parents may be carriers, and the individual may be unfortunate to have a double dose of the mutation. So the MUT gene is a human gene that encodes the DNA glycolase, a DNA repair enzyme involved in oxidative damage, DNA damage repair. During the process of replication, cell growth, you have that there is DNA multiplication, division. And in that process, if there is oxidative damage, normally oxygen can damage the DNA molecule. And then when oxygen has damaged the DNA molecule, you can have the normal guanine can be altered by oxygen. And this guanine that is supposed to bind to cytosine in the base pairs can bind to adenine. And that abnormality is the problem that occurs. But under normal circumstances, if the DNA glycolase enzyme is normal, it's supposed to cut off that, bring about a repair. But when it is abnormal, this is what leads to this abnormality in base excision repair. And these mutations eventually lead to tumor formation. So APC is a tumor suppressor gene in the cell cycle control and downregulation of beta-catenin through the Wnt signaling pathway. This Wnt signaling pathway are the major pathways, controlling locomotion, morphology, and so on, and other pathways in embryogenesis or in cell development, cell multiplication and replication. APC gene is normally involved in apoptosis of colonic epithelial cells. And the APC mutations can cause expansion of the crypt-based cell population, including crypt stem cells. Mutant crypt stem cells may clonally expand to form adenomas and carcinomas. So essentially, what the APC does is to regulate the beta-catenin. So if the APC is mutated, it no longer plays that role. It cannot downregulate the beta-catenin. And if the beta-catenin is not downregulated, there will be stimulation of cell growth and proliferation. And that is what is explained by the second hit hypothesis, with a patient with a germline APC mutation developing adenomatous polyps when there is inactivation of the remaining normal APC allele. Colorectal adenocarcinomas and familial adenomatous polyposis develop in similar fashion to sporadic type of colorectal adenocarcinomas. I've said that before, those ones that are involving the KRAS, oncogene, and the P53 tumor suppressor gene. Abundance of adenomatous polyps results in near-certain development of colorectal carcinoma. So we look at pathology, morphology, which essentially we're looking at the morphologic alterations, gross, microscopic, and then gross or macroscopic descriptions and the microscopic descriptions. So most adenomatous polyps, they are small. They are less than 0.5 cm in size and they're sessile. Polyps are more common in left side of the colon, although the entire colon can be typically involved. Polyps may be flat or depressed. And before us, we are looking at a colonoscopy view of polyps in the large bowel of someone with familial adenomatous polyps. You can see the numerous polypoid growths in the colon. Then this is a gross picture after surgery. One can appreciate, the numerous polypoid, sessile growths, on the mucosa of the colon. Then this is another view again showing us colonic mucosa being covered by several small polyps. Then this is another picture also. By way of microscopic description, we can see these are photomicrographs showing us polypoids. You can see the polypoid growths, on the colon. Then this also, in this view, we are seeing different types of polyps. Some are tubular, villous, and some are villous adenomas. And this is a much high power view, also showing those tubular, tubulovillous, and villous adenomas, on the colonic mucosa. So this is also an example of tubular adenoma in familial adenomatous polyposis patients. Similar one. This particular view, one could see, well, not very clear, but there are areas that are showing dysplasia. So similar view also. And then this is just a view showing when the polyposis have now, undergone malignant transformation, and we are now looking at a moderately differentiated adenocarcinoma of the colon with missing production. So by way of investigations, FAP, or familial adenomatous polyposis, may be suspected in people who have or had many polyps in the colon. If the surgeon is able to see that there are so many polyps, depending on the number of the polyps, the surgeon can begin to, suggest or suspect different types of polyposis, adenomatous polyposis colon. Family history is important, in this, and also the presence of hepatoblastoma, liver cancer in childhood, desmoid tumor, papillary thyroid, unique changes in the retina, a part of the retina called congenital hypertrophy of retinal pigment epithelium, especially if it is seen in multiple spots and both eyes. If you see these features, they are highly suspicious of familial adenomatous polyposis. Familial adenomatous polyposis can also be diagnosed through examination during sigmoidoscopy, colonoscopy, or essentially through also genetic testing. Genetic blood test for the APC gene is available, and this can detect those that have it, and also can predict the possibility of familial adenomatous polyposis. The diagnosis of familial adenomatous polyposis is confirmed when the gene testing shows changes known to cause familial adenomatous polyposis, called what is called pathogenic mutations in the APC gene. So pathological evaluation of biopsies taken during sigmoidoscopy and colonoscopy are also important in confirming the diagnosis. Essentially, patients' personal and family medical histories are very important. Genetic testing, family screening, especially first-degree relatives, digital rectal examination, fecal occult blood test, flexible sigmoidoscopy, colonoscopy, burying enema with X-ray can also help in highlighting, elucidating the polyps, colonic polyps. Diagnostic criteria: if you have 100 or more colorectal adenomatous polyps and germline mutation in APC, family history of familial adenomatous polyposis with colorectal adenomas, and the patient is less than 30, or there is family history of familial adenomatous polyposis and presence of at least one epidermoid cyst, osteoma, or desmoid tumor. When you have this, these are diagnostic criteria for making a diagnosis of familial adenomatous polyposis. Patients with a history of less than 10 colorectal adenomas, a family history of adenomatous polyposis syndrome, or a history of adenomas with familial adenomatous polyposis type extracolonic lesion should undergo assessment for adenomatous polyposis syndrome also. Prognostic factors: you look out for location of mutation, number of polyps, presence or absence of, like we said, other extraintestinal lesions, desmoid tumors, congenital hypertrophy of rectal pigment epithelium. Most common causes of non-colorectal carcinoma deaths in FAP patients are duodenal and papillary carcinoma and complications of the desmoid tumor. That's why it's important to also look out for these things, because they have prognostic of great prognostic importance. Genetic testing has rapidly grown in the last few years with advances in next generation sequencing technologies. Targeted testing of all polyposis patients with a gene panel can now be performed at reasonable cost, such that targeted screening and prophylactic surgery can be offered to these patients with molecular diagnosis of polyposis. Early diagnosis and treatment is the key to optimal management of familial adenomatous polyposis. Thank you for listening. Thank you for listening.
Thank you very much. Can we stop the presentation? Great. Thank you, Professor Ukekwe, and for that presentation. And I think that's a real educative and enlightening presentation on the genetics of familial adenomatous polyposis. Just before we start the conversation, I just want to appeal to everyone. If you have questions for Dr. Nwosu, who presented the case, please you can indicate by raising, just indicate with the hand symbol, or you can post your question in the site. And just for Dr. Nwosu, I just wanted to find out this patient, did your patient eventually undergo a genetic evaluation for the, even though the macroscopic picture looks classical, but did this patient undergo genetic evaluation?
Thank you for the question. We actually requested, but the finance was an issue, so they were able to go for it.
Okay.
Yeah.
Yeah. Because I know in your history, you said the mother also had or died of complications of colonic surgery. So I was just wondering if, and knowing that this is an autosomal dominant gene, so could he have got this from his mom, if that was the case?
We invited the other family members and other, but we were not able to. They had severe financial constraints.
Okay.
So we actually did more of history examination on other family members, and then advised them accordingly to present early.
And this patient, I was just wondering, would there be any avenue for even providing colonoscopy screening for them, knowing that patients who have this, they come from a family of autosomal dominant gene families, and that the likelihood of other members of the family having it is high.
Yes, he's on colonoscopy. He's on monitoring. Yeah.
No, I know this patient now we have his rectum because he's had an ileorectal anastomosis and a total colectomy. So he'll be having a rectal surveillance.
Yes.
But I'm still thinking in terms of other family members.
Yes.
Okay. Dr. Jude, you have a question?
Thank you, sir. Okay, just to add a little, because I co-manage the patient with Dr. Nwosu. The thing is, the family members were, or the patient was actually adequately counseled. We made it clear to him that there is a good likelihood that his mother had it. We also explained clearly to him the risk, for his siblings, and then told him that he needs to invite them, ask them to come for colonoscopy, but none of them came, even after repeated, counseling. Even the patient in particular even after everything, didn't follow up that is the follow-up protocol. He didn't follow it, strictly as we advised. We assume that, in fact, I think it's because of financial constraints, really. They are financially seriously constrained.
Okay. Thank you very much. I just want to come back to Professor Ukekwe for the presentation. Thank you so much. You did say that one of the variants of the familial adenomatous polyposis has a low preponderance for developing cancer, maybe older age group. And you did mention flat adenomas. One thing from observation is that the flat adenomas, even though their chances of becoming malignant, they are harder to detect, especially if you don't have high quality endoscopy with ability to be able to identify those flat adenomas. How can we ensure this patient? I know their chances of becoming cancer is much lower, but because we can't identify them early, they might eventually develop cancer, which, again, most of them, unlike the other polyps that are pedunculated, these are the flat ones are more endophytic, so they grow into the wall of the colon. And I'm just wondering, in our environment, what advice or how we can manage these patients?
Essentially, the question you are throwing at me, I think, is for the surgeons.
Exactly, I know.
Because it's the surgeons that do the colonoscopy and the sigmoidoscopy.
Okay.
So essentially, for me as a pathologist, it's for me to look at samples that come to us, and then to have in mind that you could have those types of polyps that are flattened. Like I said, some are sessile, some are flattened, some are, villous, tubular villous, different shapes. And it's not only what they call it again, familial adenomatous polyposis that can give rise to adenomatous polyps. There are other conditions which I have mentioned that can also give. So it's important for the surgeon to have a holistic look at the patient, besides the genetic testing that is available, which I think we should actually explore, because it's just a simple blood test. And with it, you can identify the genetic abnormality. You can tell whether it is the classic, you can tell whether it's the attenuated, you can tell whether it is the autosomal recessive or the MUTS gene type, the one that is on chromosome 1. So when you get that from the genetic test, then you now know what you're looking at. At colonoscopy, you look at the number of polyps you are looking at. That will help you. And then with other history, family screening and family history, one can actually narrow down to say, this is what we are looking at.
Yeah.
Thank
you very much, Prof. And Dr. Morodien, I think you raised your hand there.
Good evening, sir. Good evening, sir.
How are you, my brother?
I'm fine. I'm fine. I just want to make a little comment on the colonoscopy for this set of patients that may have a flat form of polyp. I mean, I think you already put it in perspective. You have a good quality colonoscopy. I think the key to this kind of patient is having a very good bowel preparation. Because without that, to be extremely difficult for most times. So they go on the part of the surgeon who are into the endoscopy. You have a
We've lost you. We've lost your voice there. Dr. Roa, we've lost you.
I'm back.
Okay. Yeah,
Hello?
we can hear you again now.
Yes, yeah, again. So I was just saying that part of the surgeon is to who do endoscopy, they should have a good preparation and should have good quality. That is the key to making those diagnoses and making it easy and follow them up. And for those who have a flat adenomatous polyp, those ones should be followed up more closely compared to the others. That is the key to many of them may be missed because if you're not doing good preparation and the endoscopes are just barely seeing something, even though you get to the secum at the end of the day, you may end up achieving only to get them later in the day, later that they are transformed, but you now have it in the column. Thank you, sir.
Thank you so much. Thank you. Yes, I agree with you. And currently, the endoscopes, they are actually equipped now with this narrowband image capability that you can actually change the color and be able to dictate. You'll be able to see a feed change if you use the narrowband imaging for and scoping. Any time you're in doubt, if you can focus in the area and use your narrowband, it just highlights where the adenoma is. And then if that becomes the case, it's either you do it yourself or if you have your gastroenterology colleagues who are skilled in EMR or endoscopic mucosal resection, they can do that for those flat adenomas, because the risk is to leave them. But I think if you find them, EMR would be the way to go in treating those patients. Dr. Osino, you were asking a question. So please, what is the pathology stage of this disease? I'm sure that question is for Dr. Wonso. The specimen that was taken, you said there were two synchronous tumors, one in the rectosigmoid and one in the descending colon. I was just wondering, when they were staged histologically, what were their staging, and were there lymph node involvement? Dr. Onsu, are you still there with us?
Hello, I can't hear you properly. I don't know if it's from my end.
All right. And so I was saying that Dr. Osino was asking a question. He says, please, what is the pathologic stage of the disease?
Okay, it depends on if you want to use this Spigeman staging system where you use the number of polyps, but there are things you consider in the staging. The number of polyps, the size, the histological type, and then dysplasia and all that. So all these are what is considered. And then if there are distant metastases. So in our patient now, there are no distant metastases, no liver, no metastasis any other place. And the polyps are more than 300 in number. So that's what you consider in this, the level of dysplasia, like the two obstructing lesions, they were dysplastic. And then the other polyps were not, except the one at the rectosigmoid and other. So these are the things you consider when you want to stage the INFAP.
Yeah. Okay, I'm just to be clear, I thought you said there were two synchronous tumors which are cancerous in the specimen.
Yes.
Dr. Ede, you want to comment on that? Yeah, Dr. Ede, you have your hand up.
Adenocarcinoma to overt malignancy. That one at the rectosigmoid and the descending colon. We started the patient on adjuvant chemo after the surgery, but he didn't complete it. I think he just took one or two courses and didn't come again.
Okay.
All right, thank you.
Thank you. I'm just trying to follow the conversation and see all other questions. Here. Okay, the next question from Dr. Adewale. It says, thanks for the presentation. Has the diarrhea resolved after the use of loperamide? And then Dr. Adeyanju also asked a question. So what's the present state of the patient? Has the diarrhea stopped?
Okay, the diarrhea stopped. Initially, when the patient had the surgery, he had up to 10 boil motions in a day, which was much. So with the loperamide, he reduced to up to about 5 times or thereabout. But we told him that there will be adaptation, but there will be bowel adaptation. So by the time he was visiting, he has reduced significantly.
Yeah, that's thank you. And I think the diarrhea at this stage wasn't as a result of the growth because the colon has been taken out. It's just because you have an ileorectal anastomosis, and either the use of loperamide or codeine phosphates is usually very helpful in those early stages until the patient adapts. And dietary advice will also be useful in terms of trying to reduce the amount of high fiber diet in these patients. I don't know if there's any other comments about the concept of diarrhea in patients with ileorectal anastomosis. And these patients in the early stages post-surgery, we really have to be careful because they're passing a lot of fluid bowel motion, and the chances are that they can become dehydrated, and many of them can actually go into acute kidney injuries. So it's something we have to be careful about to make sure that we are rehydrating and replacing the fluid they are losing until such a time as the high output has reduced. At least we have to ensure if there's still the volume is more than 500 mils to a liter or two, then if we don't replace the fluid adequately, these patients then can go into acute kidney injuries. No, acute renal failure, as we put it. And Dr. Oladapo Babajide is also asking a question. What is the schedule for following up this patient post-op? Dr. Monsu.
Yeah, for the colonoscopy, it's actually yearly, but it also depends on the other issues the patient has. Okay, like if the patient has the duodenal polyps and all that, you also want to factor in that. Then for each visit, patient will have a good history examination, but for the colonoscopy, usually yearly.
Okay, so you just, I think the advantage in these patients now is that since their colon is gone, you'll just be doing a proctoscopy
Yeah,
or,
exactly.
or a sigmoidoscopy for them, which is cheaper, it's more accessible, and you don't have to have a full bowel prep. You could just do a phosphate enema and maybe rectal irrigation for them, particularly if the patients can't really afford or everything that comes with that. We have two doctors there, Dr. Obohare from the US and Dr. Ayon Olatunbosu. Dr. Olatunbosu, you have a question?
Yes, sir.
Well, a question and a comment, sir.
Yeah.
Good evening, everyone. Sorry, I couldn't start at the beginning of the meeting, but I know that the patient was said to have been reconstructed with an ileorectal anastomosis. But after a while, I also heard that one of the lesions that were cancerous was a rectosigmoid junction lesion. And that got me wondering what exactly, was the size of the residual rectum that was left behind. Because my understanding of ileorectal anastomosis, where there is rectal sparing, is really to leave the entire rectum behind, because that would make it easier to control diarrhea from the fact that you're placing the terminal ileum directly, over the anus. And if that is not possible, then to either do a terminal ileostomy or do an ileoanal pouch. Some people put an ileal pouch directly on top of a short rectal stump. So I'm just wondering, there's been a lot of questions on the diarrhea in this patient. But I'm just wondering from the surgeon, what type of anastomosis was done? And to the moderator, sir, what would be your advice in this situation? If you had a rectosigmoid polyp that had undergone malignant degeneration, what would be your advice regarding reconstruction? Thank you, sir.
Okay, thank you. Thank you very much. And I think your observation is quite legit, because I think the indication both on the CT and the endoscopy says it was a rectosigmoid, which means at least at the minimum, the upper third of the rectum was involved in this, which means if you are resecting, then you have just the lower two-thirds of the rectum left. You then have to make a decision. Do you plug an ileum onto mid-rectum, which is technically challenging, or do you just do a complete coloprotectomy and then with ileoanal pouch anastomosis? But I can understand, again, you have to do what is technically feasible for you. Maybe in this case, if the ileorectal anastomosis was still the likely thing to do, then they would have done that. But coming to putting a pouch on the rectum, that creates motility difficulties later. So if you want to use a pouch, the common wisdom would be that you do an ileoanal pouch anastomosis rather than a pouch on top of a rectal stump. It creates a lot of difficulties and for a lot of patients in terms of evacuation and later post-operatively. So the advice would be, if you want to do a pouch, then take out the rectum and do an ileoanal pouch. I know Dr. Izio Bohari raised his hands there, and Dr. Bohari, do you have a comment?
Yes, this is Obohara from Amarillo, Texas. I want to say excellent presentation by all the presenters. And I think it was very comprehensive. Just as the point that was raised about the ileorectal anastomosis and the J pouch, I think in a resource-sparse environment, when the patient has limited funds, the best thing to do for the patient's interest may be a ileorectal anastomosis that also was done here. Because with the J pouch, there's a lot of complications that can arise from the surgery, such as a pouch leak and chronic difficulties with diarrhea. In the US, we typically refer these patients for a J pouch. And the J pouch is a longer procedure, as you know, but overall, it eliminates the risk for recurrent cancer in the rectal stump and eliminates the need for surveillance, especially if you do a hand-sewn or you do a coloanal anastomosis. So the rectum is removed completely. But I think overall, looking at this particular case, in the environment with this patient, this may be the best surgery for them. So you can avoid giving them a colostomy, requiring colostomy bags, which are very expensive for patients like this. And but I think overall, FAP one of the clear indications is to do a anal J pouch anastomosis. Thank you.
Yeah, thank you so much, Dr. Bohari from Amarillo, Texas. Dr. Jude, you have a comment? I'm sure you have some comments following the contributions there.
Yes, just a little bit more clarification. The distal, the cancerous lesion wasn't really rectosigmoid. I think initially we thought it was rectosigmoid, but intraoperatively it was more closer in the sigmoid. So we had enough distance. Then it's also good for me to point out that what we first offered the patient was actually an AP resection, because the entire rectum, even down to the anal canal, had polyps. So we told him, well, yeah, that the best thing, to extirpate all the polyps would be an AP resection, but the patient declined and also didn't want a colostomy. So now, we had to do the ileorectal anastomosis. Again, we thought of a J pouch, but the experience we didn't have enough experience with that. So we didn't want to do what we are not so experienced in also. The patient did promise to come for regular surveillance of those remaining polyps in the rectum and anal canal, but just like I said earlier, didn't keep to that promise. Thank you.
Okay, thanks for that follow-up. But I'm just curious now, because if you say this patient had polyps to the anal canal, it means even in your staple line, you would have been, your anastomotic line there's tendency that they will have polyps. And the thing with surveillance in these patients is that anastomosis, ileorectal anastomosis, are quite difficult to survey if you think that area wasn't free. But then the question is, what are you doing with the polyps, the residual polyps in the rectum? By the definition, and from what our esteemed professor, Professor Ukekwe, said, these patients have 100% chances of developing cancer. And I'm just very concerned in terms of if there were polyps that were on the anastomotic line, how are you going to evaluate those polyps going forward? Because you can't see them, and this man's his outcome is much. I thought maybe the rectum was clear, and that's why we left the rectal stump. But if he had the anastomosis, you see, I think sometimes we have to do right by patients. Sometimes I know many of them culturally don't want the anastomosis, or they don't want the ileostomy. But after education, that just letting this patient know the risk that they are going to develop cancer in the rectum subsequently, and it's a painful death, with patients, if they develop cancer in that rectal stump, going back to the rectum to do such surgery is very difficult, technically difficult, and most likely by the time you identify it, is locally advanced. I don't know what your views are about that. Should this patient have had an AP resection or coloana? Well, if the coloana was not technically feasible, to just do an AP resection and then an end ileostomy.
Just like I said earlier, what we offered him initially was actually an AP resection, but he rejected it outrightly. So we were sort of handicapped. We just had to do what he accepted. Well, just that he said whatever happens, he doesn't want a stomach. So we had to do that. Yes, and what you just said now, well, I wasn't aware of that. The difficulty during surveillance in an ileorectal anastomosis, I think, is a new knowledge I'm getting now. Thank you.
Yeah, and my other comment is most times if we have issues whether a tumor is rectosigmoid or not, it might be beneficial to just do a rigid sigmoidoscopy because anything that is rectum, it's beneficial to do a rigid. It gives you a clearer idea of the distance from the inner veg, because the scope might be, it's a flexible scope by your standards, so it may not give you the clear depth, but anytime you're in doubt in the rectum, a rigid sigmoidoscopy will also help you to clarify the distance from the inner veg. Any other comments would be welcome with regards to what the conversation we're having. I have Dr. Molade Adegoke made a comment or question. He said, thanks for the presentation. Just a comment on the case presentation. Adenomatous polyps by current convention are graded as either having low grade or high grade dysplasia rather than using mild, moderate, or severe. Thanks for that comment. And then Professor Abubakar Bakari, let me read the question here. Thank you for this interesting presentation. From the case presentation, that patient had the polyps from the inner canal, and there were some in the antrum. What's the advantage of doing the colectomy with ileorectal anastomosis? Professor Bakari, I don't know if you want to clarify the question or what your thoughts
All right,
are.
sir. Thank you very much for the presentation, sir. What already what I'm trying to say has been addressed. Actually, what I want to say here is, if they did this anastomosis with a rectum has full of polyposis coli, it will be a challenge as well. And then how will they follow up this patient if they are going to follow? Because from the presentation of the professor, he said 100% of this kind of patients can develop cancer. So I'm wondering, would they have done ilioanal anastomosis with ileal pouch? And he has also said there's a challenge of experience in that regard. So I say, will they have done some mucosal resection of those remaining polyps in the rectum? Will it give any advantage? So that's all what I wanted to have clarified.
Thank you very much. Any comments on that? While we are waiting for the comments, I just want to appreciate Professor Ukekwe for his presentation. I think this just brings to fore the benefits of having a multidisciplinary team approach to this kind of patient. In my institution, if you have this patient obviously will be discussed at the multidisciplinary team meeting where the surgery, everything will be planned prior to surgery. But again, we understand the resource availability, which kind of limits what you can offer the patient. So like I always say, most times you guys are working with one hand tied behind you, and I commend your efforts in everything you're doing, and in the environment you're working, you just have to do the best by the patient and what the patient allows you, or to what extent the patient allows you to go. I just asked this question to Dr. Izio Bohari, and somebody's asking a question. Dr. Kenneth Onyejukwe says, any thoughts on Elia J pouch in this case? Dr. Bokhari, I don't know if you have any comments on that.
Yes. In terms of doing an anal J pouch anastomosis on this patient, in fact, I had a case similar to this a few years back. The lady was 16 years old and came in with similar symptoms, anemia and a bowel obstruction, but she actually had two cancers, one in the cecum and then one in the rectum. I ended up doing a total proctectomy with an APR, a sphincter preserving APR, and gave her an end ileostomy. And she's been, this is about 5 years ago, so she's cancer free now. She got chemotherapy for stage 3 rectal cancer. But this particular case, it's a little difficult, especially in a resource depleted environment, to decide what to do at the spot. This patient came in with two masses, and one of them was near obstructing in the rectosigmoid junction. I think you don't burn bridges by doing an ileorectal anastomosis. If there is no cancer in the rectum, you can always come back and do a completion proctectomy with an ileostomy or a J pouch. But I think it is very, very wise to not do the J pouch if you don't have the experience with a J pouch. And a J pouch procedure, even in experienced hands, can take 5-6 hours, even with the right equipment that you have, with the right exposure, with the right assistance in the OR. It's still a long, difficult procedure. I do J pouches for my practice, for ulcerative colitis and for FAP, and for patients that have Lynch syndrome. Those are the 3 clear indications for a J pouch. But those J pouches, they end up having an ileostomy, and then you have to come back for a second operation to close the ileostomy. So these patients require multiple surgeries, to get them to the finish line. So I think deciding in a resource depleted environment with the patient's decision to avoid an ileostomy may be actually to the patient's benefit in the short term, maybe not to the long term. But again, I think that decision is made based with the doctor and the patient. Thank you.
Thank you very much, Dr. Bokhari. And I just, on that note, I know I'll have to ask our Vice President to come in here, but I want to thank the presenters and Dr. Therese Nwosu, who did the case presentation, and I appreciate your effort because I think these are the kind of cases we learn from. So all the questions none of the questions is to question your competence or any of that. It's just to stimulate conversation so that we can develop learning points from this. So I thank you very much. It was a very interesting case you presented, and we really appreciate it. And I thank Dr. Judede for your contribution also. And I want to express our thanks to Professor Francis Ukekwe, who came in. And I want to please ask you, maybe if you use your good office to invite your other histopathology colleagues, because it will really be useful if we continue to have robust conversation and with histopathologists, and even if we have radiology colleagues also, or a medical oncologist, it will really then form a complete cycle for us to have a complete conversation. But I know we are developing, and we are heading in the right direction, and long may this continue. Thank you so much. And I hand over back to Vice President.
Thank you again, Dr. Aguari. You have said everything that needs to be said. I did spy a few radiologists and 1 or 2 oncologists in the group, but most have already left now. It is important, again, this whole meeting emphasizes the importance of interacting with colleagues in sister groups that make a more robust conversation. So I want to use the opportunity to thank everybody for their time. Thank you to the presenters, Dr. Nwosu Ivanteres and Professor Ukekwe. The presentation for next month will be announced shortly in the group. Thank you very much for everybody's time. Till next time. Thank you.
Thank you very much.
Okay. Good night.
Good night.